This is our patient who presented to us with bilateral eye blurring of vision, and he was previously being denied of cataract surgery due to a positioning problem. As we can see here, he has severe cervical kyphosis, and he is unable to lie flat. Several surgical techniques have been described to address kyphosis. In this case, we modified the operating table into a reverse Trendelenburg position. Patient's head was supported with modified pillows made up of linen protectors, and the gap at his lumbar region was filled up with linen protectors to ensure the comfort of the patient throughout the surgery. Temporal approach was chosen in this case. The main incision was performed. Here we inject the Trypan Blue with air bubble to prevent the risk of corneal endothelium toxicity as the patient has an underlying corneal scar. Viscoelastic was injected to prevent corneal endothelial cell loss. Next, we proceed to perform continuous curvilinear CAPSULORHEXIS. However, with the presence of a corneal scar, the surgeon's view is affected, resulting in a small CCC, as seen here. To enlarge the CCC, we carefully make a small tangential incision in the CCC using a cystotome needle. Then, we peel an additional small crescent-shaped piece of anterior capsule at the margin in a spiral using our CAPSULORHEXIS forceps, and continue to create the ideal opening. Here we manage to create a well-centered large CAPSULORHEXIS and remove the remaining lens capsule. Next, we proceed to PHACOEMULSIFICATION. During PHACOEMULSIFICATIon, the phaco settings used are similar to normal patients. We perform the major steps of PHACOEMULSIFICATIon in a fairly normal fashion, but with more caution, because this is an unusual position for the surgeon. One of the main challenges is to maintain a good view. In normal patients, when lying supine, the iris should be at a horizontal position, parallel to the floor. This keeps the eye in good alignment with an optimal view and easier access to the tissues. In kyphosis patients, when positioned in reverse Trendelenburg position with chin down position, the tilt of the iris can make surgery more difficult. The patient can help by looking at the microscope light, but this is the patient's up gaze and that is more limited in range than down gaze or lateral gaze. Surgeons could place a single 7/0 vicryl corneal traction suture at the inferior limbus to better manipulate the eye into a more desirable horizontal position for optimal view. In this case, we tried to manipulate the eye into a horizontal position with the phaco tip while trying to focus the microscope. We did not perform a corneal traction suture as we could still appreciate adequate red reflex throughout the procedure. After injecting viscoelastic into the anterior chamber, we were very careful while implanting the intraocular lens. Fortunately, the whole process went smoothly. We slowly push the haptic in, and position the lens in the bag properly. Here, we can see that the Purkinje images are not aligned and centered due to the reverse Trendelenburg position, but we can still appreciate adequate red reflex in our patient's eye. Then, we proceed to wash out the remaining viscoelastic in the eye. We injected an air bubble into the anterior chamber to prevent wound leakage and sealed the wound with stromal hydration. The whole operation was uneventful. We then readjust the operating table to allow the patient to slowly sit up. The patient was extremely grateful for the effort that was made to perform cataract surgery and improve his vision. The post-operative period was uncomplicated, and he was happy to be watching television and reading again. So, to summarize our learning points from this case, tip number 1. Reverse Trendelenburg position with temporal approach can be considered for ocular surgery in kyphosis patient. The successful and effective performance of cataract surgery by phacoemulsification depends on the comfortable positioning of both the patient and the surgeon. Tip number 2. Injecting Trypan Blue with air bubble can help to reduce the risk of corneal endothelium toxicity. Tip number 3. If the CCC is too small, carefully extend the CCC by creating another tangential incision. This step must be performed with extra caution. And tip number 4. The surgeon can consider placing corneal traction suture inferiorly to better manipulate the eye to the horizontal position for optimal view in kyphosis patients. Last but not least, I would like to extend my gratitude to Dr. Ling for his supervision. Thank you.